We'll call to order this hearing of the Subcommittee on Efficiency and Effectiveness of Federal Programs and Federal Workforce. This morning's hearing is titled Improving Federal Health Care in Rural America, Developing the Workforce and Building Partnerships. I look forward to hearing from our witnesses about efforts made by the federal healthcare workforce to address the needs of rural America, including veterans and Native Americans. Today we'll discuss some of the challenges of this task, including efforts to recruit and retain a quality federal healthcare workforce, and we'll highlight opportunities for collaboration and cost sharing and exploring stronger partnerships between agencies and local providers. As a Montanan and as someone who has worked very closely with the veterans and the Native American population, I am aware of the challenges in rural and frontier areas of accessing quality health care in a timely manner. To address these challenges will certainly require a multifaceted approach. We need to invest in technologies like telemedicine that bring healthcare closer to home. We need to expand the number of mobile clinics and vet centers and improve transportation options for folks that are forced to travel significant distances to receive the health care that they need. But we also need to address chronic healthcare workforce shortages in rural communities in agencies like the VA and Indian Health Service. Far too often we've seen new facilities set idle because we can't recruit enough mental health professionals to a particular area, or we've seen veterans diverted for care because of nursing shortages of a particular facility. But this isn't a VA-specific problem. It's a rural problem, and it's a national problem. We need government agencies to aggressively and effectively work together to make progress and to ensure they are working in collaboration and not in competition. This collaboration shouldn't only be happening between federal agencies, it should be happening at the state level, and it needs to be happening in more rural areas. In these communities, the federal healthcare workforce needs to leverage what limited resources it has and empower local partners to more effectively increase access to care. Just because a veteran lives in a place like Havre, Montana, doesn't make him or her less deserving of a timely and quality health care. We have some great witnesses with us here today, and as we discuss these critical issues in more detail, I look forward to hearing from each of them. I'll now turn it over to Ranking Member Senator Portman for his opening statement.
Thank you, Mr. Chairman, and thank you for having the hearing today on an incredibly important issue in Montana and Ohio and around the country. It's an important topic, and I think the testimony we're going to get today is going to shed light on some of these issues facing rural health care in particular. Thanks to the witnesses for being here, this panel and the coming panels. One of the most important functions that our federal government must fulfill, of course, is the care of our veterans. We need, as we're going into Memorial Day, to think about that. You know, they are out there defending us, in essence, and their mission continues when they get home. We got to be sure we're there with them. And there are acute health care problems right now facing over 6 million veterans in rural communities, including a lack of sufficient health care providers and the need to travel, as the chairman said, significant distances to seek care in many cases. Like our urban veterans, our rural veterans returning from Iraq and Afghanistan are coping every day with both the visible and the invisible wounds of war. But unfortunately for them in the rural areas, help isn't as readily available. I'd like to discuss these topics in the context of traumatic brain injury because it's often referred to as the signature wound, unfortunately, of the wars in Iraq and Afghanistan. Department of Defense now estimates that over 266,000 service members have suffered traumatic brain injuries, or TBIs, from 2000 to 2012. At the same time, the CRS, Congressional Research Service, has estimated that over 100,000 service members who have served since 2000 suffer from post-traumatic stress. So it's one thing to be able to get our rural veterans treatment for an orthopedic issue or even help maybe on a diabetes management program, but often it's another thing entirely to present the full scope of treatment needed for a veteran suffering from the effects of TBI or post-traumatic stress. I know our witnesses recognize the scope of the problem, and each of your departments has embarked on a number of initiatives to address those problems. I look forward to hearing more about that today. I will say I am concerned that we are making internal adjustments and small steps forward, whereas the size of the problem is bigger than that. It's daunting, and the longer we take to address it, the worse it's going to become. I think our treatments that we are now providing for our veterans are not as effective as they could be, and I think the pilot projects and assessments are are important, but I think we have a bigger problem that we need to address, and that's what we'll talk about today. Tragically, we are now losing, we're told, 22 veterans a day to suicide. Fundamental changes are needed to occur from the way VA interacts with our veterans to the model for providing care, and we'll talk about that. When I'm back home in Ohio, I regularly talk to our veterans about their interactions with the VA. Some are very positive. Some of the stories I hear from our rural veterans are likely similar to what Chairman hears in Montana. Long drives, even longer drives in Montana probably. Expensive drives sometimes to get the kind of treatment that they need. Uncoordinated appointments, varying customer service. When a TBI patient who may find it difficult to remember his or her appointments, may find it difficult to follow directions or even interact with other people, has to drive a couple hours to an appointment. And when he shows up a little late after driving through a blizzard and has to reschedule his appointment for weeks later, we're not setting that person up for success. And unfortunately, these stories that I've heard are not isolated, and I know in, again, Montana, some of the same stories are out there. So we've got to leverage the resources of our nation for these men and women who have given so much to us. We have providers throughout our country who stand ready to support this population of over 6 million rural veterans if given the opportunity to do so. And connecting our rural veterans with the right treatment, I think, is something we ought to be focused on, and we'll talk about that today. So again, thanks to our witnesses. Mr. Chairman, I look forward to the testimony today and discussing these issues.
Well, thank you, Senator Portman. I would just like to say thank you for your opening statement. And as we kick off the first hearing on this subcommittee, I want to say I look forward to working with you to help improve issues, whether it's health care or something else. This is a pretty broad-based subcommittee. So
yeah, likewise.
I look forward to working with you to get some good things done. I'd like to welcome our first panel of witnesses who have all spent years in public service working to increase access to health care for rural Americans, and they've all dealt extensively with the challenges of recruiting and retaining a quality health care workforce. First of all, I'd like to introduce Dr. Robert Petzl. He's the Undersecretary of Health in the Department of Veterans Affairs. He has served in that capacity since February 18, 2010. In this position, he oversees the health care needs of some 8 million veterans currently enrolled in the Veterans Health Administration, the nation's largest integrated health care system. VHA employs over 272,000 staff members at more than 1,700 sites across this country. Last year, the VA treated 6 million patients during 80 million outpatient visits and 692,000 inpatient admissions. Welcome, Dr. Petzl. It is great to see you, and we look forward to your testimony and look forward to getting you back in Montana. Next, we have Dr. Yvette Rubidoux, who is the Director of Indian Health Service, IHS, at the U.S. Department of Health and Human Services. She has served in that capacity since 2009. IHS provides a comprehensive health service delivery system for approximately 2.2 American Indians, Alaskan Natives, from 566 federally recognized tribes in some 35 states, and they serve a critical role in my state of Montana. Dr. Rubidoux, it's good to see you again. We look forward to your testimony. And last but certainly not least, we have Tom Morris, who is the Associate Administrator for the Office of Rural Health Policy and the Health Resource and Service Administration, otherwise known as HRSA, an agency within the U.S. Department of Health and Human Services. Tom's office serves as a critical research and policy resource on rural health issues, and it administers a number of critical grant programs that enhance the delivery of rural health care. Additionally, his office works very closely with local partners to increase access and to build capacity within those communities. Tom also happens to serve on the Veterans Rural Health Advisory Committee. Welcome, Tom. It's good to have you here. There she is. We just got going. Before we go to Dr. Petzl for his opening statement, you can have an opening statement if you'd like. It's up to you. Okay. We will start with Dr. Petzl. You'll have 5 minutes for your oral testimony. Know that your full written testimony will be made a part of the record. So with that, Dr. Petzl, you may proceed.
Chairman Tester, Ranking Member Portman, and members of the subcommittee, thank you for the opportunity to speak with you today about how VA recruits, retains, and deploys a quality health workforce to ensure that veterans can access the health care that they have earned and deserve. VA is committed to providing veterans with quality, timely, and accessible health care as close to their home as possible, Veterans' mental health is a top priority for VA. As a part of President Barack Obama's executive order to improve access to mental health services for veterans, service members, and military families, VA has made significant progress to increase its mental health workforce to meet the needs of veterans. As of May 14, 2013, VA has hired 1,367 new mental health clinical providers. In addition to that, we have hired 2,063 mental health providers to fill existing vacancies. So over the last 10 months, VA has hired almost 4,000 additional mental health providers. And in addition to that, we have begun hiring a new group of people called peer specialists, and to date, 261 of them have been hired. We're aware of the challenges to recruit and retain a quality healthcare workforce and are implementing a number of creative recruitment strategies to ensure access to care for all veterans. These efforts to increase the awareness of employment opportunities include national advertisements through television commercials, public service announcements. To meet the mental health needs of veterans and their families, VA has also begun to hold facility-based mental health summits with the purpose of building and expanding coalitions with community providers, organizations in the communities, and federal and state agencies. VA is dedicated to improving access and quality of care for rural veterans by developing innovative practices to support the unique needs of veterans residing in geographically remote areas. VA has used a number of programs including Project Arch and Patient-Centered Care, or PC3, in order to provide eligible veterans coordinated and timely access to care through a network of non-VA medical providers who meet VA quality standards. VA will continue to look for and implement new ways to broaden access through innovative approaches to bringing care to veterans. Telehealth enhances health care, especially in rural and geographically remote areas where it can be difficult to recruit healthcare professionals and where travel distances are excessive. VA is a national leader in telehealth-based care. In fiscal year 2012, VHA provided care to 500,000 patients through video clinical conferencing, store-forward technology, telehealth, and telehome health. This number is set to rise to 830,000 in 2013. Specialty Care Access Network extensions for community health outcomes, or SCAN ECHO, is one initiative that VHA is using to ensure the delivery of specialty care services to improve access to specialists. SCAN ECHO leverages telehealth to allow healthcare specialists from a regional center to offer expert advice to providers in rural healthcare settings. Another initiative is My Healthy Vet. This offers veterans online access to the VA healthcare system and is designed to give them greater control over their health and wellness. Features of the system include the ability to communicate with providers, refill prescriptions, and to access their electronic medical record. VA optimizes the delivery of treatments by using technologies and tools such as mobile applications. These mobile applications can help veterans build resilience and manage their daily challenges. The award-winning PTSD Coach mobile app, co-developed with the Department of Defense, provides an opportunity to better understand and manage the symptoms associated with PTSD. PE Coach, or Prolonged Exposure Therapy Coach, is a mobile application for patients to use with their therapist during prolonged exposure therapy as a treatment companion. VA maintains partnerships and continuously seeks to foster relationships with government and non-government organizations to bring value to veterans and expand access to the care they have earned and deserve. VA has a strong history of collaborating with community mental health clinics, including federally qualified centers. These locally developed community partnerships provide mental health services to veterans in areas where direct access to VA health care is limited by either geography or workload. In response to President Barack Obama's executive order, VA, working closely with the Department of Health and Human Services, initiated 15 pilot projects to evaluate how these partnerships can help bring mental health services in areas that are experiencing difficulty in providing direct care. We're committed to building an accessible system that is responsive to the needs of America's veterans. VA continues to implement its rural workforce strategy to recruit locally and utilize the necessary resources, including collaboration, technology, and partnerships to achieve these goals. I thank the subcommittee for the opportunity to appear before you to discuss this important issue, and I'm prepared to answer any questions you may have.
Thank you for your testimony, Dr. Petzel, and we'll move to Dr. Robideau.
Thank you, Chairman Tester, Ranking Member Portman, and members of the subcommittee. My name is Dr. Yvette Robideau, and I'm the Acting Director of the Indian Health Service, and I'm pleased to provide testimony on our efforts to develop and support the federal healthcare workforce. Well, IHS's workforce plays a critical role in supporting the overall mission of the IHS as a rural healthcare system addressing a population with significant disparities in health and access to care. IHS shares similar challenges faced by rural communities across the nation. Many of our IHS facilities are in rural and remote locations where recruitment and retention of employees, especially healthcare providers, present unique challenges. IHS vacancy rates for health professionals have actually improved over the past few years, but they still remain an issue. For example, dental vacancies were greater than 30%, but an increased focus on recruitment and retention reduced those vacancies to approximately 10%. However, continued efforts to improve recruitment, retention, and support our federal workforce are critical. Over the past few years, IHS has implemented a number of reforms to change and improve the agency, and many of these efforts have contributed to better support and strengthen IHS's workforce, since many of our reforms were based on input and recommendations from our employees and our stakeholders. IHS also supports programs such as the American Indians into Medicine, American Indians into Psychology, and the Quentin N. Burdick American Indians into Nursing programs, which help develop students' interests in health professions and encourage them to return to their communities and work for IHS in the future. The IHS Health Professions Scholarship Program is a key strategy for the agency in developing the future American Indian Alaska Native workforce. The IHS Loan Repayment Program is one of our most effective recruitment and retention tools for the recruitment of a variety of positions in our workforce. IHS has worked to strengthen our recruitment and retention strategies through gathering input from our workforce and our stakeholders to better understand the needs of our workforce. And another important strategy to improve recruitment and retention is to improve the workplace environment at IHS to better support our workforce. IHS has made improvements in background checks, the hiring process, and credentialing and privileging of providers to ensure that we have a quality federal workforce. IHS has also worked to make our salaries more competitive with the private sector, which is especially important for health professional improvement. IHS has leveraged many partnerships to help develop and support its federal workforce with other federal agencies, academic institutions, and tribal communities. Our partnership with the Health Resources and Services Administration has helped us recruit more health professionals to work in IHS through their National Health Service Corps scholarship and loan repayment programs. Our partnership with the VA has helped us improve coordination of care for American Indian Alaska Native veterans through implementation of our 2010 Memorandum of Understanding and our 2012 VA-IHS National Reimbursement Agreement. Those are helping our workforce improve access to quality health care for American Indian and Alaska Native veterans. Our partnerships with academic institutions are extremely important to our recruitment and retention efforts because of the link it provides to students and new graduates seeking places to serve. One of our most powerful recruitment and retention strategies is our partnership with our communities. As more of our federal workforce feels at home and supported by those communities, the likelihood that they will become a long-term member of that community will increase. In summary, the federal workforce is essential to the core mission of the Indian Health Service and its delivery of accessible and quality health care services to American Indian and Alaska Native communities. While there is much more to do, we appreciate the opportunity to testify at this hearing to further discuss opportunities for improvement. Mr. Chairman, this concludes my testimony. I'm happy to answer questions.
Thank you, Dr. Robideau. We appreciate your testimony. We'll go to Mr. Morris.
Mr. Chairman, Ranking Member Portman, and members of the committee, thank you for the opportunity to testify today. on behalf of the Department of Health and Human Services, the Health Resources and Services Administration, about the Federal Office of Rural Health Policy. For 25 years, the office, which was created by Congress, has served as a focal point for rural activities within HHS. We're charged with advising the Secretary on the impact of HHS policies, regulations, and programs on rural communities. This includes an ongoing focus on issues related to the training, recruitment, and retention of healthcare professionals in rural communities. We also administer several grant programs related to capacity building, from community-based pilot programs to state programs focused on improving the quality and financial performance of small rural hospitals. We welcome opportunities to discuss ways to help rural communities attract and retain needed healthcare providers. This is a priority for the office, for the department, for HRSA, and for the administration. There are nearly 50 million people living in rural areas. That represents about 16% of the population, spread across 80% of the landmass of the United States. The rural healthcare system is heavily focused on primary care and chronic disease management, relies heavily on safety net providers like small rural hospitals, federally qualified health centers, and rural health clinics, as well as solo providers and small group practices. The Office of Rural Health Policy funds several initiatives to focus on building up that rural capacity. This ranges from our work with the 50 state offices of rural health, which we provide grants to, as well as our work through the Rural Hospital Flexibility Grant Program and the Small Hospital Improvement Grant Program, which works to improve quality and financial performance for small rural hospitals. HHS's investment in rural communities, though, goes far beyond the ORHP programs. For example, HRSA administers the National Service Corps, which offers a lifeline to rural communities. They support loan repayment and scholarships for healthcare providers, and almost half of those providers are in rural areas. HRSA training programs in primary care, behavioral health, dentistry, and nursing play a key role in training the next generation, and we're also heavily focused on investing in community-based residency training for physicians, whether that's through our Teaching Health Center program, in which 15 of the 22 grantees serve rural communities, or through our work supporting the 23 rural training tracks across the country. Our studies indicate that 70% of the graduates of these rural training tracks stay in rural practice, and we're focused on increasing student interest in those programs and also working with communities to start new rural training tracks. Rural areas also benefit greatly from the HHS and state Conrad 30 J-1 visa waiver programs, which place foreign-trained physicians in communities that need them the most. Our office also works with each of the states through the National Rural Recruitment and Retention Network, which placed 1,767 clinicians in rural areas in the past year. Telehealth plays a key role in increasing the reach of the healthcare workforce. We've long supported grants to link urban specialists with rural communities and needs, and yet we're seeing through our grant programs new and emerging technologies such as e-emergency care, e-ICU, as well as telehome monitoring. Telehealth technology also plays a key role in extending the reach of a limited mental health workforce, particularly in areas in rural areas where psychiatrists, psychologists are often scarce. We also currently are funding a 3-state telehealth pilot that includes Montana and Alaska to link rural veterans to telehealth and health information exchange to enhance their care. At HRSA, we're also working with a range of federal partners through the White House Rural Council to train the workers needed to operate and maintain these health information technology systems, whether we're talking about electronic health records, telemedicine, or health information exchange. We expect this to be a key job growth area in the coming years as these technologies continue to be deployed in healthcare. Thank you again for providing the opportunity to share HRSA's and the Office of Rural Health Policy's mission with you today and the efforts we have underway to focus on rural workforce challenges. I'm pleased to respond to your questions.
Well, thank you, Mr. Morris, for your testimony. At around 10:30, there will be a vote called, and what we're going to do is we'll just kind of stagger it out. So we're not going to adjourn. We'll just stagger out, and then Rob comes back. He can do it. Otherwise, if we both have to be gone, we'll kick it over to either Senator Begich or Senator Heitkamp. All right? Thank you. Could we put 7 minutes on the clock, please? Dr. Petzl, the VA has made a commitment to hire, I think, 1,600 new mental health care professionals, health clinicians, I guess we'll call them, and I think about 300 support staff. You correct me if my numbers are wrong. Where are we at on those hirings, both for the clinicians and for the support staff?
The numbers are correct, Mr. Chairman. In terms of the clinical providers, we have two ways that we look at this. One is the actual positions that were identified that have been filled, and as of the 14th of May, we have filled about 1,356 of that 1,600 clinical mental health providers. Another way that we look at this is that every quarter we are able to assess the number of clinical providers providing direct care that we actually have on board. So we went back and looked at what we had on board in May of 2012 when we began this effort, and now I have the most recent data from March of 2013, and that indicates that we've got an additional 1,556 people on board providing mental health care than we did back in May. So we believe that we're well on our way to meeting that goal. And we have basically hired almost all, within a few short, of the administrative personnel that were part of the 1,900.
What are the totals? What do you, the 1,556 additional from what they were, what are your total mental health care in the system?
Total mental health that we have, let me just take a quick look so I make sure I get this number correct, but I believe that the total mental health that we have on board providing direct patient care is about 18,600. So that would include psychiatrists, psychologists, mental health nurse, clinical mental health specialist nurses, psychiatric social workers, the master's trained counselors and master's trained family therapists.
As you well know, in Montana, and I think this could be said for all of rural/frontier America, we've struggled to overcome shortages in mental health professionals for years. So unless we're getting a healthy portion of new hires, which you've indicated we have, it's unable to make up the ground with the impacts of PTSD and TBI and the issues, the unseen, we'll just call them the unseen injuries coming back from war. You talked about where we are today. How, moving into the future, are there long-term efforts for assessment? And if so, is there long-term efforts for recruitment to go with those assessments as we move forward to help bring in more, I'll just say more young folks into the eye of rural America?
Well, first of all, Mr. Chairman, there are ongoing recruitment efforts, and these will continue because we have continuing developing vacancies. I'm pleased to say that the vacancy rate has actually dropped from slightly over 13% amongst clinical mental health providers to a little bit below 11%. And that's a significant number when you're talking about almost 20,000 mental health professionals. We are assessing and will assess actually continuously whether or not we're meeting the access needs that and the access standards that we've described. And if we discover that we are not able to do that because we do not have the personnel available, we will continue to add to the mental health workforce. But I think that it would be useful if I could take 1 minute to describe the other things that we're doing that are relatively new efforts. The most important of which is the use of telehealth and telemental health to deal with the shortage of psychiatrists, which we and everybody has difficulty recruiting into rural areas. I know you're very familiar with that. We have set up regional centers of psychiatry that communicate with our community-based outpatient clinics and provide consultation and therapy via telemental health from remote areas such as Spokane, Washington, where we're having difficulty recruiting psychiatrists, into one of these centers in an urban area where we are able to recruit psychiatrists. We have no difficulty recruiting psychiatrists to New York or Minneapolis or Houston or San Francisco. And these regional centers are proving to be very effective. The telemental health therapy is very well received by veterans. They like the idea that they don't have to travel great distances. They're not befuddled and frustrated by a 45-minute drive, even across town in an urban area. And that is going to be a major effort in the next 2 years to help us provide the psychiatric services in remote areas.
Well, thank you. And thank you for your work. Dr. Robidoux, I want to talk about some of the challenges that may be unique to Indian country as you seek to recruit and to train and to retain quality healthcare folks. Time and again, we hear about administrators who must bring in folks from outside the area as primary care docs, as specialists, as nurses. These are highly skilled but high-paying jobs, especially in Indian country. I had a group of 8th graders in my office yesterday from down at Crow, and one of the questions they asked me was, how do we get more doctors and nurses from Crow country in the Crow hospital? These are 8th graders. These are 12, 13-year-old kids that understand what's going on. Can you talk about the challenges of recruiting in Indian country?
Well, our challenges are significant, and we certainly would like to recruit more individuals from our tribal communities to work in our facilities and to be health professionals. The challenges of social and economic issues in the communities, the schools, and things like that, and then they have to travel far away for their education, and sometimes they don't come back. So our health professions programs help us recruit and retain American Indians and Alaska Natives to work in our system. The Indian preference law helps us a lot because our I would say approximately 3/4 of our employees right now are American Indian Alaska Native. The place where we have a difficulty recruiting American Indian Alaska Natives is in some of the health professions that require training at a distance from the Indian reservation, and so recruiting them back to work is a challenge, but our loan repayment programs really help with that.
Okay. I'm going to kick it over to Senator Portman.
Thank you, Mr. Chairman. Dr. Petzl, I wanted to ask a little about using non-VA providers for rural veterans. I know you've got capacity issues. We just talked about that, despite hiring over 1,500 new positions in the last year or so on the mental health side. Beyond capacity issues, where sometimes you do have to use a private or a fee service, what's the threshold? How far do you require a veteran to go to seek services? How do you define geographic inaccessibility? I know which is one of your criteria.
Thank you, Senator Portman. We have definitions of rurality that involve both distances, 60 miles would be an example, and time, 60 minutes to services. But those are not really used in any great sense when we're evaluating whether somebody should be feed, as we call it, or cared for in the community. Much of it has to do with the convenience of them being, or inconvenience of them being able to travel. If you have an 81-year-old gentleman who lives even 60 miles from a medical center, it's a burden to ask that individual to travel for a routine clinic appointment. And even for some individuals who are much closer but have to travel across an urban area, that can be a daunting task for somebody who is 81 years old. So we try to do two things. Number one, an option is feeing that care, that is providing the care in the local community, and we've got 2 pilots that are running right now looking at that option. But another one that we're using in increasing numbers is what we call telehome health. A video camera in the patient's home, instruments to monitor the patient's weight, EKG, blood pressure, and regular contact with their primary care provider at their clinic or their medical center. It's proven very effective in taking care of patients with multiple chronic diseases and in not providing them with the opportunity to not travel to a clinic. We reduce emergency room visits by 40% in patients where we've done this and studied it. We've reduced clinic visits by 38%, and we've reduced hospitalizations by almost 1/3 by providing this care in the home with a constant communication.
For mental health treatment, is that as effective as it is for other kinds of treatment? We talked earlier about the fact that we have so many of our veterans with PTSD or TBI, and so maybe for somebody who is, again, recovering from orthopedic procedure or somebody who's on dialysis, maybe you can work through some of these issues using some of the telemedicine you're talking about. But how about for mental health? Is it more of a challenge?
Telemental health is remarkably well accepted. It began actually in the VA on an Indian reservation, on the Rosebud Indian Reservation in South Dakota, almost 10 years ago now, as a study, treating PTSD by telemental health by a researcher at the University of Colorado, proved to be very successful and was really the impetus for spreading telemental health around the country. The acceptance rate by this and the satisfaction rate by this is over 90% for the patients that use it. I'll tell you an anecdote very quickly. Man lives in New Jersey, has to travel 45 minutes to get to his psychiatrist who works in one of the medical centers there. And he described live on the video camera the experience. 45 minutes through traffic, he's frustrated, he's angry, and he is not the same kind of person that he normally is by the time he shows up for that appointment. When he does a telemental health therapy episode, he's sitting in his own home, he's comfortable, he hasn't driven across urban traffic, he is relaxed, and he is an entirely different person, and the therapy session has a dramatically better effect. It works. It works very well, and we are going to be exploiting this to the maximum over the next several years.
Do you think that using non-VA providers, particularly for mental health and TBI, is something that you're doing adequately? I noticed in the data that you provided the committee that about 2% of VA mental health patients are seen by non-VA providers every year. DOD, as you know, has a policy with TRICARE that's a little different, where they use non-DOD mental health providers for TRICARE recipients on a more regular basis. What's your policy? And again, is only allowing 2% of our veterans to seek treatment by the many providers outside of the VA system appropriate?
Well, I think that should be expanded, Senator. I have no doubt that 2% is not as much as is needed and as could be, and we are, in fact, doing it. The new non-VA care arrangement called PC3 is going to have in it a mental health component, and we will be expanding that. The issues are making sure that those non-VA providers are facile with PTSD, particularly traumatic brain injury and depression, and the things that we see as a result of combat. But we are expanding, and we intend to expand our use of non-VA providers. The pilot that we're doing with the federally qualified health centers, I think, is an example of that. We've committed to piloting in 15 locations how this works when we have a contract with a federally qualified healthcare provider. Those are up and running, 15 of them. 5 more are going to be added relatively shortly, and I have no doubt that network is going to expand.
I noticed the data you provided us goes up to 2010, and it does show an increase from 2007 to 2009, actually a decrease in 2010 from 2009. But are you suggesting that your data for 2011 and 12 and 13 would show an increase?
Certainly, Senator, 12 will show an increase. I don't know what 11 looks like, but it should show, 12 should certainly show an increase.
On telehealth or telemedicine, you've given us some important information in your testimony and then an answer to my earlier question. I appreciate that. By your own count, you're seeing over 1 million mental health patients a year now. Clearly, a lot more of our veterans need this service. If we assume these patients are dispersed like the veteran population as a whole, that is at least 300,000 mental health patients would be in rural areas or highly rural areas already seeking treatment, and likely just as many who need treatment who aren't seeking it. Through these health programs that are telemedicine, telemental health programs, how many patients have been connected?
That's a very good question. Presently, it's about 83,000 patients that we've delivered telemental health services to.
Mm-hmm. And how many of those 83,000 have to go to a CBOC or to one of your community-based outpatient clinics in order to get that service?
Almost all of them, Senator, would be going to some location where we have telemental health services. There have been a few, but not many, that we have, as the gentleman I described in New Jersey, where we have set this up in their home. That's the, with the shrinking
That's the
of
a pilot program that you think should be expanded.
it's not a pilot, it's just in its infancy, and yes, it will be expanded. I think that we've demonstrated, these patients have demonstrated the fact that they're better therapy sessions, better therapy patients, when we see them in the context of their home.
Anything we can do to help you expand that capacity into the home?
I think that I think we have the resources, Senator. We have the money to buy the equipment. The price has shrunk dramatically, and it's basically just a webcam now, a high-quality webcam on a computer. The thing that we need help with around the country, all of us do, is psychiatrists. There just are not enough psychiatrists in this country to meet the country's mental health needs, much less meet the needs of rural veterans, people that are being treated by the Indian Health Service. That's probably one of our largest issues.
Thank you, Dr. Petzel. I appreciate your testimony. And Senator Begich.
Thank you very much, and Dr. Petzel, thank you very much for your work and your ties to Alaska and other work your agency has done, especially around, we call it the Heroes Card, but the work you've been doing with Indian Health Services and delivering health care services to rural veterans, especially in roadless areas in Alaska, where it's very, very difficult, as you know, to get access. I want to ask you a general question, but first, I again want to commend you for moving forward. I know our tribes have been very motivated, and hopefully I've given them the task after a period of time to be working with us on any issues that may come up to make sure we continue that process so if a veteran, no matter where they live in rural Alaska, will have access to health care and not worry about having to fly all the way to Anchorage or Seattle, depending on the service they need. Can you just give me a quick update on how that is working and how you feel the success of that is?
Thank you, Senator Begich. I wanted to just mention that I had dinner last night with Catherine Gottlieb.
Oh, very good.
From the South Central, and he said, I mentioned we were having the hearing, she said to send her regards.
Oh, very good. Thank you.
We have had great success, I think, in working with South Central and the other tribes in Alaska. The contract that we have for sharing services with South Central has been very effective in providing specialty services. We also have some instances where in more remote areas, veteran patients are being seen in tribal facilities, obviating the need to travel back to either Fairbanks or to Anchorage. So the number, and then the second issue, the number of people that are having to travel out of Alaska down to Seattle or to Portland for services has shrunk dramatically. And I would say that with very few exceptions, we're going to eliminate that need in the not too distant future. I mean, there are some quaternary things for which, such as bone marrow transplants, et cetera, which Seattle is the obvious place to go. But otherwise, our goal is to not have veterans in Alaska traveling out of Alaska in order to receive care. I think we're making progress, sir.
Fantastic. Let me ask you on the mental health, because you know, since I've been here, that's been an issue, and I appreciate, I think, the regulatory change you made to eliminate co-pays on mental health providers or on mental health services. You know, Alaska's been, and you know this, and so it's kind of repeating the obvious, that we have been on the forefront of telehealth in many different avenues, from healthcare to mental health to delivery of just about everything you can imagine through mental health or through telehealth. Do you have, if let's say I'm an Alaskan who needs services through telemedicine and my doctor is in Idaho, does that doctor that I'm doing telemedicine have to be licensed in Alaska?
The short answer is no.
Okay.
We have, first of all, in the VA, as in I think every federal healthcare entity, you need to have a license in a state, but you do not have to have a license in the state in which you're practicing. So the licensure issue is really not a problem. What you need to, the problem, if it arises, is not the credentialing, which is what licensing is about.
Right.
It's the privileging. You need to
Okay.
have that individual have the right kind of privileges in the right organization. So if a doctor in Boise was doing specialty care for somebody at the Anchorage facility, they would have to be privileged at both Anchorage and at Boise. We are working to try and smooth out this process
Good.
of privileging.
Good.
Credentialing's not an issue. It's
Thank you
privilege.
thank you for kind of splitting the two issues. I knew there was an issue here, and it's on the privileging is the situation.
Correct.
Is there anything legislatively we need to do? I know we did some stuff with DOD on their end, on active, that Senator Kelly Ayotte and I did in an authorization bill a couple of years ago to fix that problem. There was a few more issues they had, but to make sure no matter where an active military member would go, they could get their mental health services delivered from whatever doctor they had at any time. Is there anything legislatively we need to do?
Senator Begich, I don't know.
Okay.
The privileging issue is something that has to do with the regulating bodies in medical care, the Joint Commission. So the Joint Commission requires that an individual be privileged at the point where they are delivering the care. There's no law, there's not even a federal regulation that has anything to do with privileging. It's basically a requirement that the Joint Commission has. And we have been working with them to try and find ways to make it easier to have people privileged at various places. But right now, privileging is the right of the medical center or the clinic that's delivering the care.
Okay, very good. Let me again say thank you for all the work that you guys have done in regards to getting what I called the hero's card, but really delivery for health care for veterans, no matter where they live, the services they've earned and deserve. So thank you for that.
I would like to also just comment on the fact that the working with the IHS and the
Correct.
tribes in Alaska has just been wonderful. I mean, that has
They're-
been a very, very good example of federal collaboration.
Yeah,
I thank you.
they're a great group up there. Let me ask Dr. Rubidoux if I can. Again, Dr. Petzel, thank you very much for that. As you know, we have a significant problem, and again, I want to echo what Dr. Petzel said. I think our Indian Health Services tribes are doing fantastic work in delivery of health care. I would argue that we have the best, if not the top in the country when it comes to delivery in the most harsh climates, conditions, and situations. So I agree that we have some incredible and very innovative approaches that we are making headway in. But one of the issues, and you've heard me talk about this before, and that is this consistent problem of staffing packages, and how do you make sure that, you have a vacancy rate of 30% in some of your categories, as you described, but the bigger issue is we have, as you know, hospital in Barrow, one being developed in Kenai, Nome is completed, Matsu, beautiful facility. The whole top floor is empty because they don't have a staffing package. They can't deliver the services that the federal government contracted with them to do. You got about $53 million last year in the CR nationwide. Just the one in Fairbanks, TCC, will take $8 million of that. How are we going to solve this? Because, it's one thing to have a clinic in an urban area, but to get someone hired in a rural area like in Alaska, you can't do it the day they're open. It doesn't make any sense. How are we going to solve this? Because this is honestly unacceptable. And we have invested, have invested lots of money in these facilities, and then we don't staff them. What's the answer here? Because these are in rural areas.
Well, the answer is for us to work together on the appropriations that will help us get the staffing packages, and I'm pleased to report that the President's budget for 2014, in terms of staffing packages for new and replacement facilities, including joint venture facilities and federal facilities in Alaska and in Oklahoma, helps us catch up to the amounts that we need to catch up. It's been a difficult budget climate over the past few years, but fortunately through our collaboration and through our working with the tribes, our proposal for a $77 million in new staffing really helps us catch up.
Is that enough?
That's enough to catch up with the need for the facilities that are planned to be open in 2014. And so right now, we're doing our 2015 budget formulation and trying to estimate which ones will be open then as well.
Okay, let me ask one last question, then I got to go vote. And this one is, I'll use the Mat-Su facility. They have a top floor that is available. They're going to fill it up. VA has a clinic down the street that's at capacity. Doesn't have full service, but it's a clinic. Why don't we just take the clinic that the VA has, take the space that is beautiful space, put it in there and have a collaborative effort? It's all federal money.
Well, the great thing about our VA...
Is that a good idea?
Yeah, because the VA IHS MOU allows us to do that through sharing of facilities and staff, so we've started to do that, and we hope to do more.
VA, good idea?
Absolutely. We would be delighted if that kind of an arrangement worked for both parties.
Fantastic. We want to work with you specifically on that project, because I think that's a huge opportunity to create a great model. Thank you. I got to go vote.
Thank you, Mr. Chairman, and thanks to all the members of the panel. Least you think that this is an unimportant issue to North Dakota. I want to point out that the two senators whose names were invoked in the testimony were Senator Conrad and Senator Burdick, both from North Dakota and both deeply concerned over a long, long period of time about the issue of rural health delivery, whether it's veterans, whether it's our Native Americans, or whether it's just mom and dad on the farm. This is a critical issue for us, and it's a critical infrastructure issue for the development and the continued viability of rural America. And so I thank the chairman for bringing this very important issue to the forefront, and I've got obviously more questions than what I have time, and so would ask for an opportunity to submit some additional questions going forward. But I want to first make a point. We've heard every bit of your testimony across the board talking about telemedicine, talking about the need to do things a little differently, expand your capacity by using the technology. Are you so convinced that the technology is available in Indian country or in rural America? You know, the kinds of things that you think you can do in Washington, D.C., do you really believe you can do in Hoople, North Dakota? Is there the infrastructure backbone, the amount of technology, and have you looked at those issues going forward when you're promoting telemedicine as a solution?
Senator, I don't take a crack at that first. 10 years ago, the technology was clunky. It required special telephone lines that were often difficult to get into in terms of remote areas. But that whole technology landscape is changing dramatically. Number one is that we can now use a high-resolution web camera to provide the same kind of fidelity of image, et cetera, that we...
I don't mean to interrupt, but is that true in every remote location in the United States?
Well, we can put that technology anyplace, and we can then use the Internet in order to...
What happens if the Internet is intermittent and dial-up?
If it's dial-up, it works. We have not run into those kinds of difficulties in really any place. We've been on Rosebud. We've been providing services of this nature on Pine Ridge. We're going to be providing those services in Devil's Lake in North Dakota. And every place we have used it, it has been, number one, reliable, but I think more importantly, it is very well accepted by the patients. When they see that as an alternative to driving 100 miles to Fargo, they'll take it in a minute, and they like it, and they get good care with it.
Yeah.
So yes, I am convinced that this is going to be the wave of the future.
Mr. Morris, I'd like to hear your response to that, because you're beyond, I mean, your umbrella is a little broader.
Yes, ma'am. I think there are some challenges in terms of broadband access, which I think is what you're trying to get at, is there enough capacity to use the full extent of the technology that I agree with Dr. Petzel works very well. And we can get back to you for the record with I know there have been some analysis of where there are some broadband gaps. The FCC has done some revisions to its universal service program for rural health care that we think is going to be a key tool in sort of that last mile and expanded capacity for those areas. And that was just announced, I think, within the last couple of months. In addition to that, some of the investments from the Recovery Act through both the Department of Commerce and Department of Agriculture helped close some of that gap. But there are areas still that are not accessible.
I don't think there's any doubt there's still a digital divide in this country, and that's my point. My point is we can't offer a solution to the remoteness in rural health care and say we're going to solve it with telemedicine and then not have the highway that's going to take you there. And so I will pledge this. I'm chairing on the Ag Committee, the Rural Development Subcommittee, and this is an area that goes beyond telemedicine, but this is obviously an absolute critical component of rural development, in my opinion. I have a question for Dr. Robidoux as well. Obviously, Senator Begich and the work that's been done in Alaska is very intriguing to us. In North Dakota, we think we have remote locations. We think that we have a great deal of difficulty. And I would tell you that where you hear a lot of praise from him in terms of Indian Health Service, that's not what I hear in my state. What I hear is intermittent services. I hear about clinics shutting down because they don't have the capacity and don't have the staff to even open up on a Friday. That overflow goes to other hospitals. And so I'm very concerned about the long-term commitment and appreciation that you have about the concern that Native Americans in my state have about the quality of their health care.
Well, I want to reassure you that we're absolutely committed to providing healthcare services to the best of our ability to the American Indians and Alaska Natives throughout the country, including in different areas. And you're actually absolutely right. There are differences among areas. It tends to track around the difference between what the proportion of more direct service programs versus more tribally managed programs. And there's flexibilities around tribal management that are really helping Alaska do some really innovative things. But we still have the federal trust responsibility and our commitment to the direct service programs in North Dakota and throughout the regions in the country. And so we are still working very hard to try to get these same types of improvements in those programs.
And not to prolong it, but I will tell you this, that there are concerns about squashing innovation, especially in the mental health area, within the Indian Health Service because it doesn't fit with what people may see as traditional models. And I'd like to have a longer conversation with you about that going into the future. But we need to be innovative in Indian country in order to provide these services. We need to continue to develop the workforce and the technical expertise of anyone who wants to offer their services, but particularly the programs that we have at UND to train Indian doctors and Indian nurses. And if I can just indulge just one additional question on HEROES, I am very interested in looking at modeling the HEROES Health Card program that Senator Begich has been able to get a pilot on. I'm very interested in modeling that in North Dakota, and particularly as it relates to Native American veterans. And I think anyone who understands Indian country knows that very many Native Americans, in terms of a percentage of their population, serve in really double, triple, quadruple numbers in the armed services. When they come home, they have access to Indian health, they have access to veterans, but neither one seems to work for them. And so we don't want people who have chemotherapy, who are entitled to veteran services, to have to get on a bus and drive 10 hours and literally wait in Fargo another 8 hours while the other patients on the bus get their services. As somebody who understands chemotherapy, that's not a healthy thing to do to people. And so we really believe that North Dakota would be a great additional site, Dr. Perez, for modeling an Indian or modeling a HEROES Health Card in the lower 48.
We would be delighted to talk with you about this.
Terrific.
And I would just make a comment, in North Dakota and South Dakota, which is where I used to work, 50% of the Native American adult males are veterans.
Yeah.
It's a huge number.
Thank you, Senator. I got a question for Tom Morris. Tom, you're administrator of the Office on Rural Health Policy, and you're a member of the Veterans Rural Health Advisory Committee. You have a very unique, informed perspective on a lot of the issues we've talked about today. Could you tell me what the biggest challenges to greater collaboration between agencies like VA and HHS might be?
Well, we've had a good partnership with the VA, and their Office of Rural Health, I think, was created in 2007, and they reached out to us very early on to sort of learn the lessons we learned over the last 25 years about what it's like to sort of be a voice for rural within a larger organization. And that collaboration has continued. As you mentioned, I'm on the VA Rural Advisory Committee. And I think it's taken a little time for us to understand the unique challenges that the VA has and how that intersection takes place between the VA providers and private providers. But I think the fact remains that so often veterans are returning from the previous two wars, especially, are predominantly rural, and they're coming back to their towns, and they're seeing care both from their local providers, and then they may also be going to the VA for some more specialized care. And so the challenge, but also I think the opportunity, is how we can both, the private sector and the VA, can duly care for those patients. And part of it involves, making sure that as you share patient information or you do telehealth, that you meet the privacy and security challenges of the VA's firewall. But I think there's progress being made there through an initiative they have around Blue Button, which is a form of health information exchange. And we have a veterans pilot program right now that one of the grantees is in your state of Montana and also Alaska and Virginia, in which we're putting money in to put telehealth equipment into hospitals and clinics, and then reaching out to the VA so that, for instance, a veteran might be able to get their PTSD treatment from a VA provider without having to leave their home community, even if there's not a CBOC or a veterans clinic in that location. And so that program is really still in its infancy. We're recompeting it right now to award another 3 years of grants. And our hope is that it can serve as a pilot for ways that the private providers that care for veterans can also reach out to the VA in their regions and duly care for those patients as effectively as possible. And then we're in conversations with the VA Office of Rural Health about looking at a number of pilot sites, really to focus on this whole notion of health information exchange, so that as the veteran sees care in both places, the patient information, the medical record, goes back and forth between both groups.
Very good. I would be remiss if I didn't ask the question that Senator Begich alluded to, because I've got Dr. Robideau here and Dr. Petzel here, and it's the collaboration between the VA and the IHS. I would expect you both, since you're sitting side by side, to say it's working great. But what are the challenges that you've faced with the collaboration that you've done together? And that's the first question to each of you. And the second question is, do you have all the policy flexibility you need to be able to do collaboration? You're basically, in many, many cases, you're serving the same group of people. So if you could talk about what the challenges have been, and then talk about if, in fact, from a policy standpoint, if you have the flexibility you need. Whoever wants to go first, go ahead.
Well, I think that we really appreciate our partnership with the VA and their willingness to try to dig in and deal with some of the challenges we face. We are two different systems with two different authorities, and sometimes we have to work through those issues. There's also the enormous need and the distances that are really challenge us as we work together. But I've been requiring my area directors and my CEOs to work with the VA over the past 2 years and meet with them, and that's actually going really well. So we're starting to have the conversations we need to have to work through some of the challenging issues. And so that relates to the policy issues, and I think the reimbursement agreement was a great opportunity for us to understand each other's authorities and understand some of the innovative ways that we could collaborate and innovative things that we could do. And so I really appreciate our partnership with the VA, because they're willing to dig at some of the hardest challenges we're facing.
From your perspective, Dr. Petzel?
Well, I would say that in terms of Washington and here, the collaboration's excellent. The attitude, the desire to make this work for both of us, and the desire, particularly from our perspective, to serve veterans wherever they might be, is unparalleled. The issue for me is generally how this is executed locally, and on both sides. I'm not saying it's either the VA or the IHS or the tribes, but it works better in some areas than it does in others. Alaska, I think, is an example of where it works wonderfully. We have sharing agreements with every tribal organization in Alaska. We are going to have reimbursement pilots in almost all of the state. In other parts of the country, we have difficulty with our people getting together with IHS people, and I think that my responsibility is to be sure that the attitude that we evince in Washington is transmitted down to the level where the work is being done. But I would also agree with Dr. Abbott. It is, as I would look at it, in the main, working very well. We have a number of places around the country where we do sharing. We've got clinics located, from the VA's perspective, on tribal grounds. The reimbursement agreement, I think, was a huge step forward. 10 pilots piloting that reimbursement agreement to work out the kinks in terms of charges and how bills are paid and patients move back and forth. There's always room for improvement, Mr. Chairman, and that's, in my mind, at the local level where we need to be sure that people are doing everything they can do to develop these cooperative relationships in places like Devil's Lake, in places like the Crow Reservation and the Billings Clinic, et cetera.
Right, okay. Thank you all very much. Do you have any further questions, Senator Heitkamp? Okay. I just wanted to thank you all for your testimony, and thank you for the question and answer session we've had. This record's going to be open for 15 days, so if there's additional questions, and I know there will be, because I'll have some myself, and I'm sure the others will too, or additional comments want to be put in the record, certainly can do it over the next 15 days. Thank you all for your service, and thanks for being here this morning. And now we'll go to the second panel. Matt Kuntz and Ralph Ibsen, if you would come up, and we'll get the name tags changed. I'd like to welcome our second panel of witnesses who both worked tirelessly over the years to advocate on behalf of policies that improve health outcomes and increase access to care for more folks. We have, first of all, Mr. Matt Kuntz. I've known Matt for a while now. He's from the great state of Montana and represents the best of Montana. Born and raised in Helena, Matt graduated from West Point, served with distinction as an Army infantry officer. Matt's advocacy on behalf of our veterans, which is spurred by personal loss, has been recognized by President Obama. Currently, he practices law and serves as executive director of the National Alliance on Mental Health for Montana. Matt took on this role to support, educate, and advocate for all Montanans suffering from serious mental illness and their families. He's done a tremendous job in that capacity, and I'm proud of his work and the work of the National Alliance on Mental Illness. Welcome, Matt. Next, we have Ralph Ibsen. Ralph is the National Policy Director of the Wounded Warriors Project. In that capacity, he heads up research and policy development on health benefits, and economic empowerment issues for the Wounded Warriors Project. He formerly served as General Counsel at the Department of Veteran Affairs and is also a veteran of the United States Army. Thank you for your service, and welcome, Ralph. Each of you will have 5 minutes for oral testimony. Know that your entire written testimony will be made a part of the record. So we'll start with you, Matt, with your oral testimony.
Thank you, sir. Good morning, Chairman Tester, Ranking Member Portman, and members of the committee. I'm really honored to be here to testify. As you mentioned, I came into the NAMI line of work the hard way, like most of us do, but I'm really honored to try to help out as many people as possible, especially our rural vets. I'd like to start out by just saying what the view from Montana is. It's As you know, it's a very big state with 147,000 square miles, just over 1 million people, with roughly 6 people per square mile. We've got one of the nation's highest per capita rates of military service, and we're home to over 108,000 veterans, which is about 16.2% of the population. For our Indian Health Services needs, we have 12 tribes and 7 reservations with over 66,000 Montanans of Native American heritage. The scarcity of mental health professionals in Montana is pretty hard to comprehend, and really is a major difficulty for our families. But the best way to describe it is we have one psychiatrist between Billings and Bismarck, North Dakota. That's a stretch of about 400 miles on the interstate, which is roughly the distance between Boston and D.C. One psychiatrist to cover all of that area. There are fill-ins by psychiatric nurses and telepsychiatry, but one warm body. And I think that the other thing that needs to be mentioned, because it underlies everything in Montana, is the oil development in the Bakken. And our eastern Montana and western North Dakota is overtaxed with pretty much all infrastructure issues, but especially mental health. And it's taking what was a crisis and turning it into something really, really terrifying. So I just wanted to give some quick realities of what happens in Montana, especially with our vets, to show how interlinked all of these different agencies are. For instance, if there's a veteran in Darby, Montana, who goes into crisis, probably be moved 16 miles to Hamilton to stay at Western Montana's private inpatient crisis center. After being there for a day or two, he'll then be transported to Helena, where the VA's inpatient unit is. It's 100 miles, and then will eventually return to his home community, where he'll be treated either by the VA through telepsychiatry or by the private health contractor. And that's just how it looks from us. Some of the things that I think that are really good that are happening in Montana is the contracting system with the private providers. It's absolutely essential. The psychiatric nursing program at Montana State is really helping us fill the needs, and telepsychiatry has hit almost a critical mass in Montana, especially with the CMS grant for $7.7 million for Montana and Wyoming. Peer Services is developing well, and I guess that one of the things that I would really like us to see more is a residency program. I think that we all talk about how bad we need psychiatrists, but the fact is every state that needs psychiatrists also needs a psychiatric residency program. And if they're able to do some of these things, if they're able to provide the services through telemedicine, maybe there's a way to structure those residency programs a little bit more flexibly as well. And also the loan repayment programs. Our nation really relies on our inpatient psychiatrists, and how they should be taken care of in loan repayment is a little bit different than outpatient psychiatrists. Thank you, Senator Tester, and I'm willing to answer any questions.
Thank you, Matt. I appreciate your testimony. Next, we have Ralph Ibsen. Ralph.
Chairman Tester, thank you for inviting Wounded Warrior Project to testify this morning. With our mission of honoring and empowering those wounded in Iraq and Afghanistan, the mental health of our returning veterans is among our very highest priorities, and I'm honored to be here with Matt. With our focus, we see that despite extensive federal efforts, and I do want to emphasize extensive federal efforts, there remain wide gaps in meeting the mental health needs of this generation of warriors. Let me highlight one critical concern. Many who served in Iraq and Afghanistan remain reluctant to receive mental health care. Research indicates that half of those who need care are not getting it, and a high percentage of those who elect to pursue care drop out prematurely. Much more progress is needed to reverse these trends in our view. Many factors play a role in that process, but in some cases, it also appears to be a function of family issues. And while current law that you helped enact, directs VA to provide needed mental health services to immediate family members of OEF veterans, VA has not implemented that provision. To your focus this morning, Mr. Chairman, excuse me, nowhere are the gaps in meeting warriors' mental health needs wider than in rural America. VA policy says, in essence, and as discussed earlier, that VA facilities must be able to provide veterans needed mental health care, and if they cannot because of lack of on-site staff or geographical inaccessibility, other options must be used, including telehealth or contract arrangements. But even veterans who live in remote areas often encounter local VA reluctance or even resistance to authorizing community-based care. With limited exceptions, we see only modest VA use of contract arrangements to overcome access gaps. And as indicated with, excuse me, with 55% of U.S. counties, all rural, having no practicing mental health clinicians, and situations as Matt described in Montana, VA's policy of providing contract care is hardly a comprehensive answer, and with the drawdown of forces in Afghanistan, the access challenge will only grow. We do see promise in programs mentioned this morning. VA's telemental health capability has seen exponential growth, and we certainly see room for VA to greatly expand use of telemental health to engage more warriors, and are pleased that Dr. Petzl agrees, as reflected in his testimony. A second important programmatic effort was sparked by the directive in the President's executive order of last August that VA hire and train 800 veterans to serve as peer-to-peer counselors. We see that as a model for winning warriors' trust in entering into mental health treatment and staying in treatment. And we also see it as having potential in rural areas. Our one concern is that the initiative is not really targeted at supporting OEF veterans, where the need is greatest in our view. Vet centers, as you know, also incorporate a peer-to-peer model, and we see that as a key aspect of the success of that program, and are pleased again at Dr. Petzl's acknowledgement that that's a program that needs to expand. Finally, let me suggest that many OEF warriors with PTSD and other mental health conditions are also struggling to readjust to a new normal, to uncertainties about finances, career, education, employment, and no single VA program necessarily addresses that full range of issues that many young warriors face. Few, if any, VA programs are embedded in veterans' community, and yet VA and community each has a distinct role to play. For some veterans, as we see it, community reintegration may take a community-wide effort, and we see a role here for VA, but as yet no real centralized effort to harness such partnerships. With limited exceptions, VA mental health programs are generally not focused or integrated with the adjacent community, and while VA has broad authority to enter into partnership with community providers, and Congress just last year in the NDAA strongly encouraged that, we don't see much happening in that front. Finally, we believe VA should work with communities in providing needed mental health services to wounded warriors. This should include providing training to clinicians on military culture and the combat experience. Simply having more providers or access to providers who don't really understand the experience veterans have been through or PTSD is not itself a real answer. We look forward to working with the subcommittee on the important issues discussed this morning, and thank you for our consideration of our views. Happy to answer questions.
Well, thank you, Ralph. Thank you both for your testimony. I appreciate it very, very much. I'm going to start with you, Ralph, on what you just last said, because I think it's an issue that I've heard from the veterans themselves, and that's the training of the clinicians, making sure that when a veteran who has some issues goes and sees a clinician, that they actually have an understanding of what got that person to the point where they're at. How do we best do this? I mean, it seems to me that there's several steps involved, and by the way, you correct me if I'm wrong. I mean, first you have to build the partnership, and then you've got to make sure the folks who are dealing with the veterans understand what the veteran's been through. How's the best way to move forward with that from a VA perspective? Because I think you're spot on, quite frankly.
Well, Mr. Chairman, I think you've really put your finger on an important point, or emphasized an important point, and that is that the treatment process has to begin with developing a relationship of trust. And I think essential to that is that the veteran perceive that the provider understands his or her problems, understands where he or she has been. And I don't, VA has done a heroic job of training its clinicians on evidence-based therapies. I don't purport to be an educator or have insight on the best way of training, but I don't see the equivalent focus on helping ensure that those providers really understand veterans. And I do see, even as VA has expanded, has filled many of those vacancies, has hired 1,300 plus, from the veterans' perspective, when they encounter a clinician who they perceive doesn't understand them, they leave.
Yeah, I agree with that, and that's the worst possible outcome, quite frankly, as far as cure goes. Matt, despite significant investments that have been made to address the complex wounds of war, we continue to see, and you deal with this firsthand, high rates of depression, divorce, domestic abuse, unacceptably high number of service members, as has been already pointed out today, commit suicide every day. It is overwhelming, and at times it's difficult to tell whether we're actually making progress, making a significant impact on what's going on out there. We need to ensure that the VA is able to identify and treat these folks with their issues in a meaningful way, and we need to ensure that they're appropriately staffed. In a rural area like Montana, you talked about Billings and Bismarck, 400 miles away. We got a train staff, but sometimes there's no staff to train in certain areas because there aren't the mental health professionals there. So to ensure that we have accessible folks there. Now, as an advocate, you've been personally involved with this epidemic. You've seen the investments that have been made. You talked about telemedicine. Are there other things out there that are working besides telemedicine? And is telemedicine working well?
Sir, I think telemedicine is working well. It's a great, wonderful thing, and the Tribal Veterans Rep program was one of the first ones that brought it to Montana, and it is valuable. There's no question. I think that one of the other things that I thought was really good was, as you know well, the VA really struggled to staff its inpatient facility in Helena, and it just sat open, and they couldn't run it due to lack of psychiatrists. And I think that the way that they were able to change their staffing structure to use it with one inpatient psychiatrist, one outpatient, and a couple of nurse practitioners, like that willingness to adapt to what actually happens on the ground in Montana. We don't have 3 patient inpatient psychiatrist to run a facility like that. And the VA learned. Took them a while. One of the other things I think is like the peer support is critical and important, and it also provides much-needed jobs for veterans that struggle with these kind of issues. But the retention of the counselors, I think, in some ways is a bigger issue than actually whether or not they've served. I know many veterans that I talk to just say it's a matter of kind of changing bodies in front of them. And if they open up their soul and describe their combat needs, describe all their issues going on with them, and then the person's gone. I mean, like I talked to one vet that works across the street, and he had 3 counselors in a year. And I mean, I think that while we need to focus on getting the perfect right training and everything.
Multifaceted, yeah. So I mean, what's the issue on retention? I mean, why are they leaving? Is it salary? What is it? Quality of life? Why are they burning out and getting out of the business? Why are they leaving? Why are we seeing the turnover?
It's really hard to tell, sir. I think it's different for every one of them. But what shocks me is, I guess, how in the box and how constrained they are. I mean, and the limits of what they're given to work with. I do think that they are pretty heavily worked. Hopefully, they'll be working with peer specialists.
Yeah.
But also, like, they don't even give them business cards sometimes. I mean, no voicemail for some of these counselors. And how do you?
Right. Gotcha. Ralph, do you want to add anything to that as far as what's working, what isn't working, and well, just that, what's working and what's not?
Well, I've seen that same telemental health demonstration that Dr. Petzel alluded to,
Yeah.
and I would agree with his assessment, and I would agree as well with Matt's perspective on the retention issue, which I think is not limited to counselors. I do think we attempted about 1.5 years ago to survey mental health clinicians, and I would not want to suggest it was a scientific survey, but it was disturbing to see results that suggested, serious morale problems at many facilities. Now, this reflected a period of understaffing, and
Right.
so I acknowledge that as well. But many spoke of the system as top down, as failing to appreciate, the importance of allowing clinicians to build that trust relationship, of imposing performance requirements that were highly focused on evidence-based practices, exposure therapies, which, while having a solid evidence base, weren't appealing to the veterans. Many of the veterans could not handle, the dealing on a weekly basis with re-exposure to the trauma they'd experienced, and yet that was the directive from on high. So again, VA has done, I understand, a survey of its own last September on clinician attitudes. I think it would be helpful to see the results of that study. That survey would be helpful to understand the factors that drive the 10% vacancy data that Dr. Petzel cited. I think a system that honored its clinicians from those peer-to-peer counselors on up would be a system that would be a more successful one.
I'm going to ask you guys a question that I was going to ask Dr. Petzel, but didn't want to keep him here all day long. But I think you guys can answer it in maybe a better way than he could, because you're driving the bus at the other end of the experience here. Licensed professional mental health counselors, marriage family therapists, they make up about 40% of the overall mental health independent practice workforce. In the VA, they make up less than 1%. Is there a reason for that? I mean, is there, other than the fact that, is there a reason on the ground these folks, are they less desirable to be counselors or not? Or is there something out there that I'm missing other than, can you help me with this?
Sir, there may be a reason for that, but I will just say flat out, it's not a valid one.
Okay.
We need them.
Okay. Ralph, you want to add anything to that?
I wouldn't disagree with that
Okay.
perspective.
Okay, good. I want to talk about the gaps that you talked about a little bit, Ralph, in your testimony. And there are some real inhibiting things that are in our society about people who go in for mental health treatment. There's a stigma attached to it. There can be employment problems afterwards. Not because they have issues with mental health. It's because the employer might not want them to begin with. What can we do to minimize the stigma? To be able, so these folks are more likely to go in and get help when they need it, because it's curable. We know it's curable. It can be fixed. What can, or is there anything we can do about it? I mean, it's...
Well, I do think there has been, a probably 20-year or longer effort to address stigma. I think, organizations like NAMI, have played an important part in that. I think there is evidence that suggests that veterans themselves, warriors of this generation, still are distrustful of mental health care. It's not solely a stigma issue, and I think the peer-to-peer counselors can play an enormously important part in belying those views and drawing warriors into treatment and helping sustain them in treatment. I think, again, Matt's point that we have to honor those warrior employees, make them feel they are an important part of the team and make their working conditions appropriate. But I do think the infrastructure, the policies are in place to close those gaps.
Okay. Matt, do you have anything to add to that?
Sir, I have two things. One is I think we need to take the magic out of what this is through research. I mean, a really big problem with the lack of stigma is based on lack of understanding. And we don't understand the brain well enough, and especially these diagnostic patterns with the DSMs changing and everything. The best clinicians really struggle to identify what a person has. And I mean, I think because we don't have valid scientific instruments to measure whether or not people have these conditions, they're measured by behavioral health surveys, it just leads to a level of distrust, and that people don't have a way of saying, okay, my neural circuitry is disrupted, so I get help for this, like it's...
I understand.
Anything that we could do to improve that. The other thing I think is we have a lot of different anti-stigma efforts, but they don't really highlight people that had PTSD and depression in the past. We don't read about, or we don't see the anti-stigma things that talk about Winston Churchill's depression, that talk about Abraham Lincoln's depression. Some of the greatest Americans struggled with these conditions, and why don't we bring them up? So I would love to see a little bit more of that.
Okay, good. I want to talk about partnerships, particularly between the VA and Wounded Warrior Project, and there may be partnerships between NAMI and the VA that I'm unaware of, or maybe there's some opportunities for partnerships that we could make them aware of. I have been aware of, and quite frankly, been out on some programs like Healing Waters in Montana, and you mentioned the Project Odyssey in your testimony, which is maybe classified in the peer-to-peer program. I don't, or maybe it's separate from that.
Yes, sir. It has a strong element of peer-to-peer.
Yeah, I guess if you guys could shed light on programs like that, their effectiveness, and how you know, how we might be able to expand on other programs that could be, I mean, there's programs out there working with animals, horses in particular, and dogs, and just kind of talk about opportunities out there to collaborate on peer activities related to the outdoors to relieve stress.
Well, if I could follow up, Mr. Chairman, Project Odyssey is one of 18 different programs our organization operates. It's a program that takes warriors out in retreat-like settings, might be to Montana for, you know, an outdoor activity, or, you know, mountains in Vermont, wherever, but takes them out in groups, has a trained, you know, has a therapist with them, and focuses on building peer-to-peer relationships to confront for the first, you know, in some cases for the first time, their post-traumatic stress disorder or other combat-related mental health conditions, and has been very successful in, you know, helping veterans confront those issues and get into treatment to overcome the stigma and barriers. And it's a program that we've run for a number of years and ran in collaboration with VA and its Vet Center program. And to our disappointment, VA pulled out of it in about 2010. The suggestion was they lacked the authority, or felt they lacked the authority to continue. Since then, Congress last year enacted legislation making it crystal clear that that authority exists, and we had hoped that that would lead to reinstitution of that partnership. That hasn't happened yet.
Matt, do you have anything to add?
Yes, sir. I got my favorite program for this. I'm totally biased because I was involved in help starting it. My sister, Dr. Janet Sherrill, and a veteran from Missoula, Jesse Skolin, started up. It's called Exports for Vets in Missoula. And what it is they take, it was based on taking veterans riverboarding. I believe it was a 6-week program. And it engages them in an extremely high adrenaline activity. And then it was tied in with counseling afterwards. And the level of success in what I saw from that program was just astonishing. And the veteran participation, they not only joined it and they got involved in it, but they took it over themselves and run it. And it really is amazing. And it is done in partnership with the Missoula Vet Center. And I know it's a model that could be expanded to other sports and stuff, but the neat thing about this, in comparison to some of the other ones, is it's not a retreat. It's kind of, it takes them in their community in a sport that they, or something that they can do afterwards, and gets them involved with a group of men and women that they eventually form bonds and friendships with, and it also introduces them to civilians like the rafting guide that helped start it. That was the first civilian that some of these vets had bonded with, and they respected him because he takes a little tiny raft on the Loxo River, and it really is remarkable, but I haven't seen any efforts from the top to try to expand that beyond Montana.
Last question. This is going to be a quick one for you, Ralph. Who funds your Project Odyssey now?
We get donations, typically small donations
all private
from around
sector.
the country. Yeah, it's all private sector, no federal,
right.
federal money. We don't take federal money.
All right. Thank you guys very much. I want to thank you again for your testimony this afternoon, or this morning. I very, very much appreciate it. I think overall this hearing has underscored some of the important progress that I think we've made, but it also highlighted some additional efforts that we need to make. And I look forward to working with Ranking Member Portman and our witnesses here today on these issues to make sure that we can address the health care needs of our citizens and they're met regardless of where they live. And in that regard, I just want to thank you two fellows for being here again this morning. Appreciate your work. This hearing record will remain open for 15 days for any additional comments or questions that may be submitted to the record. And with that, the hearing is adjourned.